Good morning and welcome you all 22nd batch of 5th year student of Jalalabad Ragirava Medical College. Today's our discussion topics is ureteric and urinary bladder calculus. I am Dr. Shaikadi Chaudhary, Associate Professor, Department of Surgery, Jalalabad Ragirava Medical College. First we discuss the anatomy of the urinary tract. Ureter are a pair of thick-walled cylindrical tubes which convey urine from corresponding kidney to the urinary bladder. It has three parts. Upper part from pelvic ureteric junction to upper part of the sacroiliac joint. Middle part from the upper to lower part of the sacroiliac joint. Lower part from lower part of the sacroiliac joint to ureteric opening in the urinary bladder. There are 5 constrictions of the ureter. At the pelvic junction, at the level of crossing the iliac artery, then juxtaposition of the vas deferens or broad ligament, and while entering the urinary bladder wall, and lastly in the intramural portion of the ureter near the ureteric orifice. So these are the constrictions point. Ureteric calculus. A ureteric stone is usually renal origin. Nature of the stone is same as that of renal stone. They can get impacted in the various anatomical narrowing of the ureter. So these are the pictures shows the stones are impacted at the site of constriction. Clinical features. Main clinical feature is the pain. The pain is colic in nature that radiates from loin to groin. It is very important one. The colic pain radiates from loin to groin, external genitalia and the anterior surface of the thigh. May radiate to the tip of the external genitalia, testis in the male, labia major in female, referred along the genitofemoral nerve when the stone is in the intramural portion of the ureter. Most stones pass spontaneously down the ureter, but when impacted in the anatomical narrowings, give rise to more persistent dull pain, often felt in the iliac fossa. The pain is increased by exercise and lessened by rest. Clinical features. Next features is nausea and vomiting due to the pain and reflux pylori spasm. Another one is hematuria. Almost every attack of ureteric colic is associated with microscopic hematuria which lasts for a day or so. More profuse bleeding is uncommon and should raise the suspicion that the colic is caused by the passage of clot. The another sign is the pyuria is likely to develop when the ureter is obstructed. The stasis of urine causes the organism to grow. On abdominal examination, there is tenderness and some rigidity over some part of the course of the ureter. The principal difficulty on the right side is to distinguish symptoms and signs of ureteric colic from those of acute appendicitis and acute cholecystitis. The investigations, the first one is a plain X-ray KUV region. Most ureteric calculi are radiopaque and are visible on the plain X-ray. The stone may not be seen along the line of ureter if it is very small or if it is obscured by the contents of the gut or being superimposed with adjacent bones like transverse fossa of the vertebra and sacrum. In that case, the stone may not be clear-cut visible in the plain X-ray KUV region. Intravenous urography, the confirmatory investigations, not only confirm the diagnosis but also allows to assess the anatomy and function of the kidney and the ureter. Can detect hydroureter and hydronephrosis. Look, the picture on the left side is normal in appearance. On the right side, there is a hydroureter and hydronephrosis. There is a hydronephrotic change. The upper ureter is mildly dilated on the right side. Other investigations, ultrasonography. Ultrasonography has less value in detecting ureteric stones. but it has great role in detecting back pressure changes, hydronephrosis, hydroureter. Plain CT scan of KOB region, it is a very important investigations. It is a non-invasive method. It is more accurate method to assess the presence and location of the stones. Look that picture on the above. There is a stone in the upper ureter on the left side, which causing the kidney become hydronephric change there. The other picture is, look there. There are two stones into the pelvic cavities, and both the stones are situated at the vesico-ureteric junctions. So bilateral vesico-ureteric junction stones seen in that plain CT-QB region. But looking the plain X-ray picture of the CT, it is very difficult to diagnose these stones lying in the vesico-ureteric junctions. So CT scan can evaluate very easily what is the stones and where is the location, what are the back pressure changes, you can easily visualize. Other routine investigations like complete blood picture. Whenever there is a stone, there is infection, always there is a raise. In case of infection, the total count is raised. Urine routine and microscopic examination is very important investigation tools because it indicates the patient having any RBC, microscopic hematuria, there are RBC present or not, past cell present or not, and what is the cast. The cast also indicates the types of the stones also. Serum creatinine needed to investigate because the serum creatinine level, if impaired, it indicates that the patient having renal function is impaired. If the serum creatinine level is raised, blood urea also if raised, it indicates there is some impairment of renal functions. Serum electrolytes also indicators of renal functions. Serum calcium and uric acid level some helps to detect some types of stones. So the treatment plan. Conservative treatment, that means expected treatment. For pain, you prescribe the NSAID such as diclofenac or indomethacin can be given. For small stones less than 0.5 centimeter, which are likely to pass spontaneously unless they are impacted, advise the patient to drink plenty of water, and sometimes we prescribe some diuretics like furosemide may be administered to flush the stone. Tamsulosin, selective alpha receptor blocker, may be administered, which helps to pass stones to relax the muscles of the ureter. Progress of the stone is followed by X-ray QB region every 6 to 8 weeks. Treatment. Indication of surgical removal of the ureteric calculus. When you go for surgical treatment for ureteric stones, that means whenever there is a repeated attack of pain and the stone is not moving, it is fixed in position, you must remove it out. Stone is enlarging in size, complete obstructions of the kidney, which is causing hydronephrotic, and ultimately the patient may having a non-functioning kidney. For that reason, it needs to remove the stone. If the urine is impacted, it must be removed out. Stone is too large to pass, so in that case is needed to surgery. Stone is obstructing a solitary kidney, or there is bilateral obstructions. In that case is needed to remove the stones earlier. What are the procedures for removal of the ureteric stones? So there are various methods of surgery. Commonly we practice the minimal invasive techniques. It is more favorite and available. It can done very safely. That means Dormia basket extractions, ureteroscopic stone removal, ureteric metotomy, push bank followed by ESW or PCNL, lithotripsy in situ, either pneumatic or laser lithotripsy, and open surgery like ureter or lithotomy. So what about the extraction by Dormia basket? So before extraction of Dormia basket, you must need to visualize it by introduce the ureteroscope through the urethra, go to the bladder, go inside the ureteric opening, go into the internal lumen of the ureter, and go up to the level of the stones. Then if the stone is small enough, which can grasped by the Dormia basket and remove it out. So stones are removed by use of wire baskets under image intensifier control has been replaced by ureteroscopic techniques. There is a significant danger of ureteric injury, and the basket should be removed, should be used for small stones that are within 5 to 6 centimeters of the ureteric orifice. Ureteric stone removal, semi-rigid or flexible ureteroscope. An ureteroscope is a long endoscope that can be passed transurethral across the bladder into the ureter. The ureteroscope is used to remove stones that are impacted in the ureter. Stones that can be cut in baskets or endoscopic forceps under direct vision are fragmented using an electrohydraulic or laser litholapaxy or pneumatic litholapaxy.
Is inserted through the urethra and bladder into the ureter or kidney. Ureteroscopy is used to remove kidney or ureteric stones and enables a direct view of the ureter and kidney to confirm or rule out other abnormalities. This animation shows the removal of a kidney stone. Ureteroscopy is typically performed with the patient under general anesthesia. A small tube is passed through the urethra into the bladder, and from there, up into the ureter and into the kidney. A contrast study may be performed to assess the anatomy of the renal collecting system before stone removal. A contrast agent, or dye, is administered through the tube into the ureters. X-ray images clearly outline the urinary channel and exact position of the stone. A so-called safety wire that helps guide the ureteroscope through the ureter is inserted. Depending on the location of the stone, a rigid or flexible ureteroscope is passed through the urethra into the bladder, following the safety wire into the ureter, the small tube that drains urine from the kidney to the bladder. Once the stone is located, it may be pulled out directly with a so-called stone basket, or a laser is used to break the stone into smaller pieces.
So laser is applied to broken the pieces. Though the video is shown stone is removed from the kidney pelvis, the same similar fashion can done in the ureter also. Holding the stone to the abdominal basket and remove it out.
After stone extraction, the collecting system is checked to ensure that no residual stones have been missed.
Then put a JJ stand
Your
inside
doctor
the
may
ureter.
place a temporary small tube, called a stent, within the ureter at the end of the procedure to ensure that swelling does not block the drainage of the urine. A catheter, which is a tube placed through the urethra into the bladder, may be used to drain the bladder. This catheter remains in place with the use of an inflated balloon. The catheter and stent are usually removed shortly after the procedure. You can leave the hospital once you are able to empty your bladder sufficiently and you have no fever or pain.
So, after any instrumental manipulation of the ureter, always we put a stent within the ureter, because whenever there is a friction of the urothelium, after friction there is the urothelial edema and causing some temporary luminal obstructions. For prevention of the obstructions, we routinely practiced after any ureteric or perineal pelvic surgery, we put a stent within the ureter and pelvis and keep it there at least 3 weeks, then remove it out. So this is about the ureteroscopic litholapaxy methods. So if the stone is impacted in the vesical junction within the mucosa, so in that case is needed to remove the stone by making an incision over the mucosa of the ureteric opening. So this is ureteric myotomy. For a stone impacted in the intramural part of the ureter, careful endoscopic incision with a diathermy knife will enlarge the opening and free a stone lost in the intramural ureter. then remove it out with the Dormia basket or Helix evacuator. There is a complication may develops which is called the vesico-ureteric reflux. We know the ureteric opening in the trigone and the external part is obliquely enters inside the muscles of the urinary bladder, go obliquely and enters into the corner of the trigone. So that obliquity can maintain the reflux, prevent the reflux of vesicular reflux. So whenever you make an incision there, so that constriction mechanism may disrupted, which may subsequently develop whenever the patient void intravesical pressure is raised, some urine comes forward to the ureter and some urine may back enters the ureter, which is called the vesico-ureteric reflux. It may develops. So another method is push bank followed by ESWL or PCNL. That means the stone is lies in the upper part of the ureter. So in the upper part of the ureter, the stone is handle is very difficult. For that reasons, some surgeons they likely to do it. They push the stones from below by a guider or by a or ureteroscope and push into the pelvis. Then whenever the stone is migrated into the pelvis, then the put a stent there, so the obstruction is relieved. Stone situated in the pelvis or the calyx. Then according to needs, availability facilities, then go for ESWL or PCNL. If the stone is small enough, it can ESWL can sufficient to broken the stone. If the stone is to some extent larger enough, in that case PCNL, if facility is available, go through a small hole in the back and remove it out from the kidney to the exterior. So this is called the push bank followed by ESWL or PCNL. A stone which is lying in the middle or upper part of the ureter can often be flushed back into the kidney using an ureteric catheter. The reposition calculus is secured by a JJ stent. So whenever you put a stent there, so there is less possibilities to migrate the stone from the pelvis to the ureter subsequently. Then the patient can be referred for ESWL or PCNL. So another one is the lithotripsy in situ. A stone in a part of the ureter that can be identified by the help of ureteroscope and can be fragmented in situ by electrohydraulic, pneumatic or laser lithotripsy. So there is lithotripsy in situ. And sometimes some surgeons prefer to do an ESWL from exterior whenever the stone is lies between the transverse processes of the two vertebrae. In that case, sometimes they can use to directly go ESWL without doing the ureteroscopic approach. And lastly, the treatment is ureter lithotomy. It is the only option when the minimal invasive procedure failed or where there is no facilities other than open surgery. Because all the time, all the patient not able to afford the minimal invasive surgery costing. So in that case, the treatment option is ureterolithotomy. That means open the ureter, remove the stone and repair the wound. The incision must be appropriate for the position of the stone. It is very important thing one. And before doing the operation, at the day of operation, you must do an X-ray. Otherwise, you can miss it. Day before surgery, whenever do an X-ray, it reveals that the stone in the upper ureter. And after 24 hours, the stone may migrate down into the lower ureter. So if you make an incision in the upper part, you can fail to identify and isolate the stone. For that reason, better to do an X-ray on table if facility is available. Otherwise, on day just before operation, you do an X-ray, and better to do an X-ray on a lying posture because you do the surgery in a lying posture. So lying posture KUB X-ray done for that reasons. The incision must be appropriate for the position of the stone. Calculi in the upper third of the ureter are approached through a loin or upper quadrant transverse incision. For mid ureteric stones, muscle cutting like iliac fossa incisions or gridiron incisions. For lower ureteric stones, fenestral incisions. These are the approach. The level of the stones can dictate which type of incision needed. Ureter lithotomy. The ureter is exposed in the retroperitoneum. So no need to open the peritoneum. So after cutting the muscles, retract the muscles, then retract the peritoneum, the retroperitoneal space is exposed. You dissect blunt and sharp, and you can easily identify a hollow tube vertically lies near the vertebral body. So the ureter is exposed in the retroperitoneum, and the slings are applied above and below the calculus to stop it from migrating away from the operative field. The ureter is incised longitudinally. After giving two stay suture over the ureter, then make an incision longitudinally directly onto the stone, which is freed from the adhesion by blunt dissection, and remove the stone with forceps. Soft catheter is passed upwards and downwards 5 or 6 French downwards to flush the ureter and the pelvis to ensure there is no other stone is there. The patency is okay. Then throw the ureter to wound. Introduce a JJ stent. After that, the ureteric wound is closed with interrupted absorbable sutures. The drain is left in place to drain urine leakage until it ceases. So this is about the ureteric calculus management. Now we can discuss about the vesical calculus. So the types of vesical calculus are primary vesical calculus and secondary vesical calculus. The primary vesical calculus is the one that develops in sterile urine. It often but not necessarily originates in a kidney and passes down the ureter to the bladder where it enlarges. So this is called the primary vesical calculus. What about the secondary vesical calculus? Secondary vesical calculus occurs in the presence of infection, bladder where there is a bladder outflow obstructions or impaired bladder emptying, or a foreign body such as non-absorbable sutures or metal staples or catheter fragments remains in the bladder, which encrusted it and ultimately forms the stones. These are called the secondary vesical calculus. Whenever a stone number is 1, then it is called the calculus. Whenever the stone number is multiple, then it is called the calculi. The true term must know everybody, must clear it. Singular is a calculus, plural number is called calculi. So the peak, there is a kidney stone, migrate to the ureter, and ultimately go to the bladder. So composition and cystoscopic appearance. The triple phosphate calculus. It is composed of ammonium, magnesium, calcium phosphates. It occurs in urine infected with urea spreading organisms like protease, which splits the urea to ammonia produced. It tends to grow rapidly. It occurs rarely on a foreign body. It is dirty white in color, chalky in consistency, and most of the cases you look, it is laminated. So in the Jafrong stone, usually these are not laminated one. But in the stone which is formed in the human body, it is formed in a laminated fashions. So you can remove the pill layer by layer. If you're broken, it can break possible. So oxalate calculus, it is primary calculus that grows slowly. Usually it is moderate size and is solitary. Its surface is uneven mulberry types. Sometimes it bristles with spines. Although calcium oxalate is white and the stone is usually dark brown or black because of incorporation of the blood pigment on it. What about the uric acid and urate calculi? Are round or oval, fairly smooth and vary in color from pale yellow to light brown. They may be single or multiple. They may occur in patients with gout but are also found in patients with ileostomies or with bladder outflow obstructions. Cystine calculus occurs only in the presence of cystinuria. It is radiopaque because of its high sulfur content. What about the clinical features? Males are affected 8 times more frequently than the female. It may be asymptomatic and found incidentally during cystoscopy before a prostatectomy is carried out. Frequency is the main symptom, is the earliest symptom. Although it is more common during the daytime, there may be a sensation of incomplete bladder emptying. It is very important thing of the frequency. It is more common during the daytime. That means it is common in the during the working hour. If a patient having a night guard, so his work on the night, rest on the day, so the symptom is more marked on the working hour. Because whenever the patient work, the blood is dependent down, it irritates the trigone and the patient's sense of micturations. For that reason, the earlier symptom it is more common during the daytime frequency and maybe incomplete bladder emptying, because whenever the patient boiled some amount of urine, then the stone is for the weight that depend down and placed over the internal opening of the urethra. So whenever they over the opening of the urethra, internal opening, then the micturition becomes stopped. For that reason, the patient developed incomplete bladder emptying. Pain, most often found in patients with a speculated oxalate calculus. Most often found in patients with a speculated oxalate calculus, because the rough surface irritate the mucous membrane, so there is more pain. It usually occurs at the end of micturition. Pain is referred to the tip of the penis or the labia majora, although very rarely to the perineum or suprapubic region. The pain is worsened by movement. In young boys, there is screaming and pulling at the tip of the penis with the hand at the end of micturition are indicative of vesical calculus. It is very important findings. In a young boy, whenever the patient is screaming and pulling the tip of the penis just after micturition, it indicates some irritation after empty the bladder. The stone is go down and irritate the trigone that irritate causing reflex pain into the radiate pain to the tip of the penis. So the child becomes screaming and pulling the tip of the penis. Tip of the penis because not tip of the glans, because whenever the patient is circumscribed, then the pain is pulling the glans. Whenever the child is not circumscribed, then the penis tip, that means pupil skin become pulling. So tip of the penis is the best to answer. Uncircumscribed child, tip of the prepuce. Or circumscribed child, then tip of the penis, then pulling. Stanguria may be present. Interruption of the urinary stream. It is very important findings. Results from the stone obstructing the internal meatus, which causes interruption of the flow. After changing the posture, flow of urine is again regained. So change the posture, the stone is dislodged from the opening to the laterally or posteriorly. Then there again flow. If small stone is impacted in the prostatic urethra or in the external urinary meatus, then the patient develops acute retention of urine. Be careful about it. In a big stone or phosphate stone, never ever develop acute retention of urine. It just interrupt the flow. But in a small stone can always capable to whenever enters inside the urethra, the prostatic urethra is blocked and there is chance of development of acute retention of urine. Be careful, that is frequently asked in the exam or in the OSPE. There is sometimes some students give the answer wrong. In a big calculus, never ever written there acute retention of urine. The other is hematuria. It is a result of stone abrading the vascular trigone, a fact that also accounts for pain. Symptoms of urinary infection are also common presenting symptom. So what are the investigations? So investigations from simple to complex. The very simple investigation is urine, routine and microscopic examination. So that microscopic examination reveals hematuria, pus cell may present, crystals that are typical for the calculus, for example, envelope like in case of auxiliary stones, hexagonal crystals plates in case of cystine calculi. What about the plain X-ray? In plain X-ray, most of the bladder stone can easily visualize by doing a plain X-ray. That means in most cases the stone is visible on a plain X-ray. And in the pelvic cavity, the radiopaque shadow. Look at the picture. It is a plain X-ray QAB region showing a rounded shape radiopaque shadow in the pelvic region. If you look very carefully, there are some laminations. Some of the stones were very clearly seen in the X-ray lamination. So if the very clear visualization seen lamination, then say there is a laminated appearance. So that indicates it is most likely it is vesical calculus. The other investigation is important one, which is called the ultrasonography. That ultrasonography can give the information that reveals presence of a stone within the bladder. That means echogenic structure with casting acoustic shadow. Look the picture. There is a white structure seen. That means echogenic structures. And there is a shadow there. So echogenic structure, casting acoustic shadow, most likely it is stones. So whenever there is a hard stones, always there is a shadow present. So the sonographic language is echogenic structure, casting acoustic shadow within the urinary bladder. It indicates there is a stone in the urinary bladder. Echogenic structure, casting acoustic shadow. So the treatment. The cause of the stone should be sought and treated. This may include bladder outflow obstructions or incomplete bladder emptying in patients with neurogenic bladder dysfunction. So whenever you go for treatment for the stones, so parallelly you need to treatment for prevention of further stone formation. For that reason, the etiology must know why the stone is developed in this particular patient. So the obstruction of flow are that patient may having a benign of the prostate, or the patient may having a associated with stricture urethra, or the patient may having associated with a metal stenosis, or if the patient having neurogenic bladder. So in that cases there is a no normal mechanism of constriction and relaxation. Bladder contraction is not possible. So the relaxed bladder and retain urine long time they are voiding is not possible. So in that case there is sedimentation. So sedimentation, ultimately there is a needles formation and stone formation. Or in some case of neurogenic bladder, the patient needs a long time catheterization. So whenever a patient having a long time catheterization, the balloon is inflated inside the urinary bladder. So the balloon and the catheter tip, there is an encrustation, sedimentation, and that may act as a needles formation for stone formation. So for that reason, in case of long-standing catheter remains there 5 months, 6 months, 7 months unnoticedly, in that cases patient may develop along with stones encircling the urinary bladder catheter balloon. So treatment needed for the stone and along the etiology. So treatment options are surgery is the mainstay of treatment. So without surgery, the stone is not possible to come out. So the treatment options are cystoscopic, litholapaxy, suprapubic, open cystolithotomy, and another one is suprapubic percutaneous litholapaxy. Whenever the bladder stone is broken inside, it is called the stones lapexy. It is broken down by mechanical or by other means like laser or pneumatic lithotripsy or electrohydraulic lithotripsy. So by any means, the stones can broken piecemeally. Then we can remove it out through the cystoscope by the dormia or the forceps or by helix evacuator. We can evacuate the stones and remove the stones, so treatment is complete. But be careful about it. If the patient having associated with stricture urethra, you don't able to go the surgery through the urethra, because the stricture urethra means narrowing of the lumen of the urethra. You don't able to introduce the cystoscope or lithotripter through the urethra. So in that cases, you treat the stricture and you treat the stone by other means, by suprapubic or percutaneous litholapaxy. Otherwise, your treatment is not complete. If the patient having a prostatic enlargement, so in the same setting, you can treat, first do the litholapaxy, then you can do the transurethral resection of the prostate. So you treat the etiology also, so you can completely treat the patient. Otherwise, your treatment is half done. So be remember about the etiology. What about the cystoscopic litholapaxy? Look at the picture. So there is an endoscope and there is a handle. So whenever the handle are grasped by your hand and close the handle, then the stone is engaged within the jaw of the lithotripter. By making a pressure over the handle, so the stone is broken piecemeal and came it out with the lithotripter. So this is the cystoscopic litholapaxy, mechanical litholapaxy. So it is under general anesthesia or spinal anesthesia, whatever it is available, you can do it. Cystoscopy is passed and the stone is visualized. It is fragmented by optical lithotripter or by a holmium laser or electroarterial lithotripsy or ultrasound probes. The bladder is flushed using an irrigator by Freyr's evacuator or irrigator or helix evacuator. So all the stone fragments are evacuated out, put a catheter for 24 hours, remove the catheter, the patient can go home. What about the contraindication of cystoscopic litholapaxy? So the contraindications are too large stone. Too large stone, so that means if you fragment the stone by laser, too much time is needed. So long time urethral manipulation causing there is subsequent urethral stricture formation. For that reason, too large stone is not go for litholapaxy. Or whenever the patient has stricture urethra that cannot be dilated sufficiently to negotiate the cystoscope. So for that reason, it is contraindication for cystoscopic litholapaxy. And another one is contracted bladder. It is very important thing. Contracted bladder, which is another name is thimble bladder. That means whenever the patient having a catheter long time, 4 months, 6 months, 1 year, so the bladder normal function is distension and evacuation is not functioning in that time. So all the time the urinary bladder become collapse. So subsequently the urinary bladder becomes shrink. Or the patient may having a tuberculosis of the urinary bladder, which causing mucosal damage, and ultimately there is a submucosal scarring, and the bladder is not capable to dilate distended more, which is called the thimble bladder. So if there is no space of distension, you don't able to hold the stone with the lithotripter. For that reason, the contracted urinary bladder is a contraindication. For that reason, I always prescribe whenever a patient having a catheter, always you clamp the catheter 3 to 4 hours, then remove the clamp 10 to 15 minutes, again go for clamping. So that gradual always clamping causing the urine is accommodated inside the bladder is capable to distend and maintain its normal function. For that reason, whenever you do a catheterization, so after doing, you can clamp until and unless you repair the bladder. If there is a bladder injury, repair it. In that case, initially 5 to 7 days, you need to continuous catheterization for complete rest of the urinary bladder. And another important factor is that when the patient age is below 10 years of age, that means whenever their child there is a external genetic smaller in size, so urethral caliber is also small. So small urethral caliber cannot negotiate the cystoscope. For that reason, it is contraindicated in case when patient age is below 10 years. Don't go for cystoscopic litholapaxy. In that case, you go for either suprapubic cystolithotomy or suprapubic percutaneous cystolithotomy. So what about the suprapubic open cystolithotomy? So this operation is done by a fenestrel incision. It is a quarterly convex incision in the suprapubic region 2.5 centimeter above the suprapubic regions, extended from one border of the rectus abdominis to the another border of the rectus abdominis. Then skin, subcutaneous tissue are incised transversely. Then the rectus sheath is incised and the rectus muscles and pyramids are retracted. The head side of the table is down, so the viscera is migrated down, and urinary bladder is full with the normal saline by a catheter, so the bladder is distended, came forward in the operation field. Then bladder is opened near the fundus and stone is removed. Open before opening, you make two stage suture there and make a vertical incision. Then this urine is sucked out, stone is removed with the forceps, stone only forceps. Then the bladder is closed, keeping a drain in the retropubic space, wound was closed. So this is called suprapubic cystolithotomy. So the key point is the position of the patient during operation of suprapubic cystolithotomy, tilting down, 10 lumbar position, head down. So head down helps to migrate the viscera towards the head side. So there is a less chance of injury to the gut. And before opening the urinary bladder, always we make sure by aspirate the content, is there urine or the gut content. If it is urine, then you make an incision there, otherwise not. So this is very important tips for suprapubic open cystolithotomy. Sometime ask in the viva examination or operative surgery, how can you identify the urinary bladder? So the answer is, by aspirating the content, we can confirm it. How can you prevent bowel injury? So by position of the patient, head down, so the viscera migrated down, and the bladder is distended with the Foley catheter with the normal saline. So we can prevent the injury to the gut. What about the suprapubic percutaneous litholapaxy? This is the same procedure, the suprapubic cystolithotomy. In case of suprapubic cystolithotomy, we make an incision, dissect the muscles, retract the muscles, identify the bladder, and make a stage suture and open the bladder. Here it is different. You distend the bladder. When cystoscope cannot be passed by the bladder is approached suprapubically, that means the bladder is filled with the normal saline, distended. Then throw a needle, guided needle, confirm the urinary bladder, then throw the needle, put a guide wire. So through the guide wire, the tract is dilated with the fascial sheath. Whenever the sufficient diameter is achieved, then the nephroscope is passed to the urinary bladder and the stone is sold or fragmented and removed out through the sheath. This is called suprapubic percutaneous litholapaxy. So this is about the ureteric stone and bladder stone. So do you have any question? You can question in the comment box in the Facebook Live, or any other time you can ask with the messenger or other direct question. So thank you everybody. Thank you for patient sharing. Thank you everybody.